So mechanisms of bacterial pathogenesis. Again, keep in mind that pathogenesis means how does a microbe cause disease. And that remains as one of the most important objectives for each and every microbe, whether it be bacteria, virus, fungi, or parasite. This lecture will discuss what is there in the arsenal of bacteria to cause problems, and then again, how can we prevent that happening, because that's where the disease process will come. We'll also keep in mind that it's pretty simple, and especially this lecture itself is an overarching lecture because that will kind of summarize the 9 bacteria or 10, 11 bacteria that we have discussed so far, and also the one that are coming up later. But I want you to start thinking as to what gives bacteria a chance to cause problems to us. And again, there is a mechanistic issue over here, and we need to find out. So if you pay attention, I'm pretty sure that you can make a good concept, and then you can commit it to your memory later on. Now, other than the basic concept of commensal bacteria, we already discussed that commensal bacteria, normal flora, we call it normal flora, it's good for us. We need those bacteria. They are our friends. We don't want to wash them away. We don't want to kill them by antibiotics because they keep the normal ecosystem that we have. Now on the spin side, also keep in mind that the temperature that we have, and some of the places on our body, the humidity that we have, and the warmth and other nutrients that can emanate from our body or can provide a nutritional source to a particular bacterium will provide a safe niche for this bacteria to find a home. And also remember that bacteria over time have acquired those genetic traits. That's why they are surviving. There hasn't been a time, to our knowledge, that we really got rid of bacteria. So they pretty much have survived. So again, the same rule, survival of the fittest. And if you pay attention that this information is being passed over and over again through binary fission, which is normal division of the bacteria. And also, if you want to challenge bacteria by antibiotics, they have even taken that challenge and come up with resistance. And we pretty much see that. Now, they know how to invade. That's the number one thing. They are invaders. They also have means to adhere and colonize, whether it be temporary or permanently. And then they basically gain access to the food sources, as I said earlier, that sits within us. And then finally, they have picked up a system or developed a system, or they already have a system where they can escape our host immune and non-immune protective responses that we may have. So these are some of the major things that we have to keep in mind. But also keep in mind that whatever is good for bacteria is bad for us. So they find a nice place to live on, but at the same time, since in their metabolic pathway, they produce acids and gases, and that may be troublesome, and it may pose problem at the minimum, or at the maximum cause damage to our tissues. So when these factors get out of control and they cause damage, we call them virulence factor. We call this bacteria virulent bacteria. We call this bacteria pathogenic bacteria, so on and so forth. Now, these factors, if you pay attention to that, These factors basically are genetic traits, and they have given this bacteria to cause disease. And right from the beginning of the structure of bacteria, talking about the capsule of the bacteria, talking about the toxins released by bacteria, they all are their survival mechanism. But at the same time, the same mechanism that helps them, this is the one that challenges us, and we have to take the brunt of it, and they cause a problem to us. As I said the other day, they all need to grow. And incidentally, our tissues and blood remains as one of their favorite growth media. So especially for those bacteria who want to escape and be a part of our blood, septicemia, they will love to be there because they have hemolytic capability. They're looking for cells. They find millions of cells there. They come up with lipases. They come up with proteases. They come up with all set of enzymes that are there to break apart each and every structure in our skin, in our connective tissue, in our different parts of the body to really cause problem to us. So let's take these mechanisms one by one, and I'm pretty sure I tried my best to keep myself limited to your book, so you can have a good reference to go back to. So bacterial virulence mechanisms. So these are some of the bacterial virulence mechanisms as a journal, as a whole. And some of them will have more and some of them may have less. As a rule, as I said yesterday, if they have more, they're more virulent. If they have less, they are less virulent. So the very first thing the bacteria has to do is that it has to adhere. It has to cling on. It has to latch on to our skin, mucous membrane, different parts. And I also told you an example, like for example, you're breathing in air in and out, and there's a pressure there, right? And sometimes you sneeze, you built up an immense pressure, and that kind of puts them at risk, so they have to be exhaled. So urinating, defecating, many things, normal secretions are being, coming out of our body that should normally wash them away. But they need to adhere, so they have those special proteins, those special pili, hair, you name it, that will give them an advantage. Then they basically have to invade, they have to get into that. That's another important virulence factor. And then again, once they start dividing, they would produce gases and acids, right? So that again will cause problem to us. That's why many a time, if you see discharges, whether it be a urethral discharge, vaginal discharge, or any discharge, even your sputum, and it tends to give odor. So that's like a fishy, smelly, rotten kind of an odor. So that odor is coming from bacterial fermentation, from metabolism. The color of your phlegm, for example, you had a clear phlegm, and all of a sudden it becomes yellowish, greenish, things of that nature. So that basically becomes sticky. It shows that something is going bad. Then they have enzymes that will degrade our tissues. We call degradative enzymes. They have proteins that will lyse our cells, cytotoxic proteins. They come with endotoxin. We talked about superantigen, that they can come and release the superantigens like staph and strep, and then play around a havoc with their immune system. So they use our protective response to cause damage to us. And then again, they can also sometimes induce excessive inflammation. Normally you would think inflammation is good. Of course it's good. But everything under control, within limit is good. So that can be exaggerated. That again works for them. They can evade phagocytosis. And of course, if they evade phagocytosis, not only that they will protect themselves from neutrophils, but also remember, even antigen-presenting cells have to phagocytose or endocytose or take this foreign material into, break it apart into smaller epitope to be put onto MSC class 1 or class 2 to be presented to T cells. So they can even evade that. They have a capsule. We found out that they are resistant to antibiotics, and they have an ability to hide within our cells. They kind of hibernate. They go over there and disappear. We call this intracellular growth. Not only disappear, but they actually grow within that. So that's like a safe haven from them. And safe haven in terms of being protected from antibodies, being protected from many things. So these are some of the factors that you will see. So whenever you look at the pathogenesis of a particular bacteria, and we talk about the primary virulence factor, this is what should come into your mind immediately, that when you're asked what is the pathogenesis. So you should be familiar what we are talking about. So questions like this can come. For example, the question can be asked, what are the primary virulence factors of bacteria? So you are given a choice. So of course, since I just discussed with you, you pretty much know what the choice is. Pretty much all of them are. Then some of the questions may ask you, bacteria, do they have virulence mechanism? Yes. Is it that they always have more than one or only one? Well, it says only one virulence mechanism. What it suggests to you is the one dominant one. Not that the others are not there, but this is only one major one that would cause the problem, and we're going to go after that. Now, some other questions can come like this. In this way, we want you to compare the virulence factors of different bacteria. For example, in this case, you already discussed Staphylococcus aureus. We already discussed Corynebacterium diphtheria. We have not discussed Escherichia coli. But again, by the end of the day, you should be familiar as to what is going on and what are we talking about. And also remember when I said earlier in one of the lectures for Corynebacterium diphtheria, if bacteria has one pathogenic mechanism, that's a good candidate for us to make vaccine against, because you're just dealing with one problem. Now in this case, you can see, of course, as I said just now, has only one. But if you look at Staph aureus, it has tons of virulence factors. So the more virulence factor a bacteria has, the more variation in terms of clinical picture, the more variation in terms of tissue injury. And you can see adhesins, degradative enzymes, toxin, catalase, coagulase, so on and so forth. So this means it's going to go after your skin. That's why you see that kind of a spectrum of skin diseases in terms of a boil, furuncle, impetigo, all different kinds of ability of this particular bacteria to cause disease, because they have more than one virulence factor. And C. diphtheria, you saw, had only one, so it was easy for us to deal with that. Now, another question normally is asked that there are different strains of a bacteria. So can we have a different strain producing a totally different virulence mechanism? Of course, the answer is yes, because E. coli, within E. coli, when we'll discuss E. coli, Escherichia coli, you'll see there are many different strains, and each one of them is categorized in terms of producing a specific entity of disease. So they may have a dominant or a prevalent or important, unique virulence mechanism that we can separate them out into different groups within one species but different strains. Okay? Now, as I already said, we pretty much have spent a full lecture on normal flora. Just to repeat that they basically are there, normally should not cause disease, but if you give them opportunity, they can become opportunistic bacteria to cause disease. And as I said earlier, they serve important function. They aid in digestion, lactase, they produce lactase to digest lactose, so on and so forth. They produce vitamins like vitamin K, and then again, they can protect the host from colonization with pathogenic microbes. So they take all the seats, like in this hall, so there's no seat left for pathogenic bacteria to come. So if you leave those seats vacant, then pathogenic bacteria may find those niches and will come and cause problem. Then again, as we discussed earlier, they are everywhere, different parts of our body. But again, normal flora bacteria can be harmful if they enter normally sterile sites of the body. That's pretty much the case, because even if they exist on our body, they are not inside our body. So normal flora of intestine, oral, vaginal, right, and on skin is still sticking to our body, but it's not entering into us. So there's kind of a difference. So our tissues and blood are sterile. But if there is a problem there, the ulcer there, cut there, anything of that sort, you give them a chance to find a good opportunity to cause problem to you. We talked about virulent bacteria, you pretty much know. We talked about opportunistic bacteria. Also remember, as I just said, that opportunistic bacteria, if you have a cut or you have an opening, but at the same time, also keep in mind that your immune system also creates that invisible barrier. It's like an invisible barrier. You don't see that, but it is there, right? So there's a visible barrier that you see in terms of integrity of skin or mucous membrane, but there's an invisible barrier where immune system is patrolling and surveying, and they would not let this bacteria to come in. But if you have immunosuppressed, right, and if you are taking drugs for immunosuppression, then again you give them a chance to come and cause problem. Especially for Pseudomonas aeruginosa, as I said, that is because the skin is exposed after burn, right? So the normal flora will take over and cause infection. And then also lungs of cystic fibrosis patient, because they're unable to get rid of that enzymes there, which are there in terms of the mucus production. And then again, AIDS patients are very susceptible because they have a problem. Their T cells are deficient or lacking. And you remember, as I said, any bacteria that wants to grow into a cell, antibodies cannot reach it. Now T cells should be there to help you out. And then if your T cells are not working, so AIDS patient who have deficiency of CD4 T cells will have problems with T cell mediated immunity, and they will also have secondary infections like mycobacteria. So TB patients, TB wasn't a problem in this country. They used to think it's a problem of Asia or Africa, but ever since they saw AIDS patient, they started having TB. So incidence of TB has risen because of immunosuppression that we normally see in AIDS patient. So the first important thing is that bacteria have to invade, have to get into our system. And again, remember the same two barriers, skin and mucous membrane. And then again, also remember some of the concept that is going to be a little bit repeat for you, that the surface structures of most bacteria are powerful stimulators of host responses, because many a time they have LPS, right? And they basically, it is good for us, because the moment they try to enter in, so the alarm, immune system is alarm. It's going to crack down on that. There's a very acute response. And then you have interleukin 1, interleukin 6, and TNF alpha especially secreted right away, because we want to create that emergency and want to help you out. And interestingly, the host response to this bacteria, which are protective, but they themselves become the cause of the symptoms that you normally see. So they basically go out of control. Like, for example, you have a very good response in terms of a cytokine cascade, but if it's not controlled, it's overblown, then this cytokine cascade will cause shock. And then shock itself will cause a problem. So remember yesterday I said STD and STI, and said sexually transmissible disease. That is established disease where you see signs and symptoms. But infection may suggest that you have an infection, but that infection has not been translated into disease yet. It may or may not, right? So try to kind of get that basic concept. And then again, also keep in mind the difference between colonization and infection and disease. What we normally mean by disease is that there's a tissue damage. So when there is a tissue damage, and there basically many a time this tissue damage is initiated, it's more like a friendly fire. So immune system is going to go after your bacteria, so in the process it's going to cause damage to the tissue. That's what you see in hypersensitivity reactions. That's what you see in many other. So if you have that kind of an activity, so your bacteria basically is, for bacteria, it's win-win situation, because it's causing problem to you, and you really have to deal with your own tissues, let alone dealing with bacteria. Now, when we say a disease production, a bacterial disease, as compared to a viral disease or parasitic disease, so on and so forth, what we are trying to say is that, as I said, bacteria is there, it wants to come in. We have innate immune systems going to fight out. We have adaptive immune systems going to fight out. They will try their best. Bacteria is strong. It has got pathogenic factor, virulence factor. The fight will go on. Sometimes you win. You would not have a infection or disease. But many times, the bacteria is in larger number. You're immune suppressed, and there are some other factors that will initiate this bacteria to basically develop enough number of bacteria, enough strength to basically go and explore your different parts and look for especially openings that you have. So you can see that over here, skin, you're pretty much protected, right? And mucous membrane. So it's a closed cavity per se. But again, there are openings, mouth, conjunctiva is like on the front of the eye, very thin layer, urogenital tract, alimentary tract. So you will see mostly bacteria will be circulating and going around in circles within these different routes that they normally take, unless and until they find a scratch, they find an opportunity, they find something there to go or get attached and wait and cause problem. And again, you can see some other factors that you have an injury, or sometimes you have a vector. Vector means a third party, where you have a flea, you have a mosquito, you have a fly, anything that will bring a totally different bacteria will try to inoculate you. Like in this arthropods mosquito is going to inoculate into your vessel, malaria, Plasmodium falciparum. So that, of course, is going to be assistant to causing disease. So this slide would suggest to you that for bacteria, portal of entry is important, where the bacteria is entering from. Especially for yesterday, I remember I said Neisseria gonorrhea. So the portal of entry is sexual transmission, right? The same bacteria, if it was to touch your skin, may not have adhered to your skin, may not have clung to your skin, but since it goes and attaches itself to vaginal epithelium, then the epithelium per se will attach to it and will allow it to go into urogenital tract and cause symptoms. So this is a good table. Again, it's more of a cram material for you, that bacteria can have different ports of entry. So these are like generic. So you can ingest bacteria, you can in the food, in the drinks. You can inhale bacteria in the air. You can be exposed to bacteria by trauma or accident. You may have a needle stick injury, or some of the arthropod bite, like mosquito, fleas, and so on and so forth. Ticks, they can also help you get infected. And then again, sexual transmission in another thing. So what you see over here is that, and what I see over here is that ingestion, inhalation, sexual transmission, 1, 2, 3, the major one where most of the bacteria will go, this is where bacteria passes mucous membrane, right? And then trauma, both skin and mucous membrane. Needle stick, again, skin. And arthropod bite, basically skin as well. So you can see all protective coverings are channels. So for ingestion, you can see from here, these are the bacteria, and they're pretty much the same bacteria that will cause food poisoning. So if you're asked, what are the bacteria causing food poisoning? What are the bacteria causing diarrhea? what are the bacteria causing gastric ulcers, so on and so forth. So all the symptoms pertaining to ingestions are here. And they basically, we will discuss each one of them separately. We may have discussed some of them, I believe, Clostridium botulinum, that releases a toxin. And then Bacillus cereus, Listeria, Brucella. These are all can be contaminants of milk and meat and food and so on and so forth. So FDA basically keeps a check on that. You can inhale, people can cough on your face, talk to you, you know, you sit next to a person, so you basically are getting that. So that is their inhalation, TB, Mycoplasma, Legionella, Chlamydia, so on and so forth. So these are all where people is there in atmosphere. Trauma, Clostridium tetani, needle stick, Staph aureus, Pseudomonas, arthropod, Rickettsia, Ehrlichia, Coxiella, and so on and so forth. And we discussed yesterday sexual transmission, Neisseria gonorrhea, Chlamydia trachomatis, that's #1 STD in this country, Treponema pallidum causing syphilis, we will discuss in the next set of lectures. So these are 3 of important bacterial. Remember, we're talking about bacterial. The list will go on and on when we add viral, parasitic, and fungal. So I did discuss colonization, adhesion, and invasion. I'm pretty sure that you will be clear on that. Now, these are some of the examples in terms of mechanisms. So you have this, as I said earlier, you can prepare your own graphs and tables and so on and so forth, but this particular chapter is good, and that's why I discussed in the end, because it has made those tables for you, so you can compare one with another. It looks very simple when you talk of one bacteria, but you really need to compare and contrast. So you can see from here, for example, Staphylococcus aureus has an adhesion. One is called LTAs, slime, lipotecoic acid. That's what it is, lipotecoic acid. And then again, Streptococcus pneumoniae has a protein. And then many times we know, or others we don't know the corresponding. Like, for example, we talked about CD4 bind with MSC class 2, CD8. So we know the corresponding complementary receptor. Some of them are under investigation, and some of them we pretty much know because we want to stop that happening. We want to stop that happening. So you can see from here, lipotecoic acid, M protein binds through fibronectin. So you have a choice either to block it or to block that because you don't want them to come in contact. And again, you can see Escherichia coli, we have Fimbury, and they have a mannose. So you can see from here quite a good amount of work has been done. But the only thing which is lacking is that you would normally not see right now in terms of the drugs that we are using to block those receptors. So we need to find out what is it that we need to block under bacteria, one type of drugs, what is it that we need to block on our surfaces, other type of drugs. So we can kind of stop that adhesion because adhesion is a virulent factor. Neisseria gonorrhea, it has a fimbriae, like a hair-like projection. It binds to gangliosides that are ganglioside D1, very specific receptors on vaginal epithelium. Then we have Treponema pallidum causing syphilis, different adhesion molecules, fibronectin, which pretty much is the same, right? Chlamydia trachomatis, it has cell surface lectin, and it binds to N-acetylglucosamine. Mycoplasma pneumonia has a protein 1, binds to sialic acid. Vibrio qualia has a type 4 pili and binds to sugar molecules. And then again, you will see that some of them are common and general, and others are not, right? So this table itself, you know, if you really have to cram it, memorize it, because you can see that some of the questions, I can just tell you, for example, fibronectin is common for Streptococcus group A, is also common for Treponema pallidum. And if you remember, the pathogenesis of these two, they are related to each other. Which of the following bacteria will have a fibronectin as a receptor for adherence? And you know what the choices are. So that's what the question is going to be like. And then which of the following bacteria we want to use a glucose molecule for as a receptor for attachment? So you have Staph pneumoniae, galactose, You have fucose and mannose over here, and these are the two important ones. And then again, for this part of the class, of course, I'm not going to detail out the drugs that are there and the drugs which are there in the making. That will tell you actually what do they do in terms of blocking that up. Actually, I was hoping if I do get time, this morning I searched that, especially for Neisseria gonorrhea, there is especially a receptor on top of the bacteria, and they came up with one of the drugs to kind of envelope that receptor. So if you give that to the people, or sometimes they want to kind of attach it to condom, they want to make sure that if it touches that bacteria, it would not allow it to invade and cause infection. So these are like drug delivery mechanisms. Okay. So by the end of the day, pathogenic actions of those mechanisms, by the end of the day, they want to achieve tissue destruction. I don't know whether they want to achieve or not, but by the end of the day, that's what they get. That's what we get. They release toxin. Some of them are exotoxin produced by bacteria, endotoxin. They are cell wall components. And again, I've said, maybe I repeat, you have to make a table, difference between exotoxin and endotoxins. Okay. Now, I just said that bacteria causes cell death. Now the question is, how does it cause cell death? And what do you mean by cell death? So for example, let's talk about C. diphtheria. We already talked about it. So C. diphtheria basically has a toxin that's endocytose. And I said what it does is that it inactivates elongation factor 2, which is required for protein synthesis. So if it kind of inactivates that, there would not be any protein synthesis, and there will be cell death. Okay, so that's the mechanism of pathogenesis for C. diphtheria. If you look for Vibrio cholera, it also has a toxin. This is a toxin as well, but this toxin is different. This is going to attach to ganglioside receptor on intestinal cells. And then they will be taken in, and the way it works is that it increases adenylate cyclase activity. So this particular toxin then will cause increase in cyclic AMP, and that will cause loss of these electrolytes. So what's going to happen is that you lose electrolytes and have a diarrhea. So that's going to be the primary pathogenesis factor for Vibrio cholera. That's why people who get cholera, they basically, we would rather spend much time to take care of the toxin. We want to spend more time to supplement and compensate for the fluid and electrolyte loss. And then, of course, we can take care of the bacteria. So this mechanism over here, this is very important for you to remember. This is another mechanism very important for you to remember, because the thing is that we learn from bacteria. Whatever bacteria does to make an action, we want to mimic that. We want to reproduce that when we go for drug development. So we pretty much use the same thing. And finally, we did discuss that two different forms of Clostridia, one causing spastic contraction and one causing flaccid contraction. And you can pretty much see over here that the inhibitory transmitters are blocked as compared to over here with the toxin blocks acetylcholine receptors. So that basically will cause same bacteria, different strains, and then they're causing different actions by producing two opposite types. So make sure you understand the difference between spastic paralysis or flaccid paralysis. The mechanism are different, but the net effect is the same, as I said the other day, because for respiration you need contraction and relaxation. If you lose either of them, you will have a big problem. Okay. Immunopathogenesis, I would not spend much time because we already spent 20 lectures on that. And so that's where it's going to come for your basic understanding. When we've been talking about antigens, we're talking about antibodies, cytokines, hypersensitivity reactions. So all these different players that we've been talking about in immunology now will come and play, because bacteria are foreign. Again, your concept of immunology, self versus non-self. right? How your body is going to respond. What are the innate mechanisms over there? What are the adaptive mechanisms over there? What are superantigens, so on and so forth. So I will leave it to Anju. I'll just touch upon some of the important things. And again, those of you who are still struggling in finding a good concept, I would again encourage them. For every bacteria, there is a pathogenesis, especially immunopathogenesis. And most of the drugs that are coming in the market are going to target that. Now, superantigens, pretty much same concept. The bacteria release that. They cause activation of T cell, polyclonal T cell activation. There is a massive cytokine release. And if you remember, some of these are produced by viruses, mycoplasma, and bacteria. And basically, they are good for bacteria and bad for us. And by the end of the day, if it's uncontrolled, chaotic kind of immune response, then it may lead to autoimmunity, it may lead to apoptosis. And you can see from here, normal antigen presentation as compared to short circuit, where they release something and superantigen come. We talked about the tampon story for the toxic shock syndrome. Remember, that was a massive cascade of pro-inflammatory cytokines that caused the shock in those young girls using those tampons. And then again, MSC class 2 needs to talk to CD4. Normally, antigen should be there, but there's none. So it kind of bypasses that super antigen and fools the system and then creates an uncontrolled cytokine release. Endotoxin, as I said earlier, many times is a very potent stimulator of immune system. So rightly so. That's why I said that gram-negatives are difficult to handle because they have endotoxin. And these are the problems of endotoxin. So if you are asked what are the features of endotoxin shock, pretty much the same answer. What does endotoxin do? Pretty much the same answer. So endotoxin basically will cause fever, is going to cause initial leukopenia, decrease in the number of leukocytes, and later increase called leukocytosis. It will activate complement, it will cause thrombocytopenia, number of platelets will decrease in the blood. Then it will cause disseminated intravascular coagulation, DIC, where you have small little coagulums developing in very small capillaries, and then again will compromise the whole system and cause problem. Because if you have those little plug-ins into microvasculature, the blood flow will be decreased, and the perfusion of the vital organs which are required in terms of oxygen delivery will be lost. And then again, shock and ultimately death. This is a slide from your immune system. I just told you, if you have LPS, and this is what it's going to cause, a havoc, whole very strong immune response that you would not know what to deal with. So we'll have a problem with the blood flow, we have a problem with the blood pressure, we have a problem with the complement, we have a problem with the liver. Everything is messed up and is very difficult to treat. And you can see all these kind of problems: increased vascular permeability, disseminated intravascular coagulation, fever, hypoglycemia, and it all is coming from LPS, which is a very potent stimulator of T cell calling polyclonal activations. Okay, we did discuss what are the mechanism, general mechanism for bacteria to evade host defenses. So you just have to think of same mechanisms that we've been discussing in immunology as well, and they pretty much are there as an arsenal for bacteria to protect them from getting cleared by our immune cells. So you can see from here, bacteria have a capsule. They come with an antigenic mimicry. This means that the antigens are the same as you, so your body would not mount an immune response. They can mask the antigen. They can shift the antigen. They can themselves come with an anti-immunoglobulin protease like Neisseria gonorrhea. It has an IgA protease. It can destroy the phagocytes. It can inhibit chemos. You can see everything that you normally need for a good immune response. Every step that we have discussed for a normal good acquired or adaptive immune response, the bacteria will have a capability to either inhibit it, stop it, or decrease it. And you can see all these things basically are there that we have been discussing so far generally. Now, one of the questions, especially in the first 10 lectures usually asked, and that's again, I think you'll see in the book as well, name capsulated bacteria, name uncapsulated bacteria. And I think your book has a good number of tables. You can find it on the net as well, but they are important. This is a list of the bacteria that have a capsule. And all these bacteria are important, and either we have already discussed it or we will discuss it because they are all important. So we have at least 25 bacteria we think are the most important bacteria, and you can see a list of them over here. For example, staph is there, we discussed. Strep 3 we have discussed. Bacillus anthracis causes anthrax we have discussed. Neisseria gonorrhea and Neisseria meningitis we have discussed. And then some of more are coming up. They all have a capsule. So they would challenge our immune system. And then again, these are the bacteria that we have important in terms of especially complement deficiencies, in terms of some other immune responses that we normally get. Another question usually asked, name intracellular pathogens. So these are intracellular pathogens. And for example, if a person gets infected by a TB, you know how many bacteria do you need to get TB? 1. You see, you just need 1. As compared to Vibrio cholera, you need millions of them. So if that is the case, I mean, this is like a hypothetical, theoretical thing. So this bacteria, like Mycobacterium species, lepri or whatever, it will go in your tissue, your macrophages, and sit over there forever. And it gets reactivation. That's another thing. We'll discuss reactivation when we talk of viral infection, because that is a quality of viral activation, latency, and reactivation. So if you have, like, for example, a chicken pox, your baby, so in the later part of your life, you may have shingles. If you have chicken pox vaccine, so it can come and reactivate, like varicella zoster virus, again as a shingle after 50 or after 60 years of age. So this is a thing where they go and hibernate and disappear in the system, and they get reactivation, right? And they go through that phase called latent phase. So this is a concept for virology. We'll discuss that in detail when we go there. But intracellular pathogens, you can see quite a few of them are there, and chlamydia, listeria, salmonella. So people can also, that's where we say sometimes people are carriers. When we talk of salmonella, typhoid, people can carry it. Shigella, Yersinia pestis, and Legionella. So this is an important concept, that these bacteria go and divide intracellularly or disappear, and then also evade phagosome-lysosome fusion. Okay, now I just said, how come bacteria avoid phagocytosis? They can either inhibit phagosome-lysosome fusion, neutrophil phagocytosis, the bacteria. So it's called phagosome. Neutrophil has a lysosome. So lysosome has to come and attach with phagosome to release all this toxic material. Bacteria are smart enough. They would not let that happen. So that's why they sit and divide in intracellularly forever. And these are Legionella, Mycobacterium, and Chlamydia. Okay, let's see. Even if you are able to cause lysosome to fuse with phagosome, they are resistant to that. So they have, you release those reactive oxygen species, you release those reactive nitrogen intermediates within your lysosome, attach it to the phagosome, and they are going to fight back because they have lysosomal enzymes. So they'll go over there and kill your lysosome, and they are Salmonella, Typhimurium, Coxiella, Mycobacterium lepri, Leishmania. Sometimes they also get adapted to cytoplasmic replication, so they'll just get over there and feel free to replicate in your cytoplasm with no problem. No lysosome is going to come and cause a problem. Listeria, Rickettsia, and Francisella are important part of that. So you can see from here, generally, that bacteria does pose a challenge to us. And we are not there only, especially for pharmacy, to go and treat the disease, right? Okay, we'll treat the disease, tissue injuries, so on and so forth, but we need to find out the mechanism of pathogenesis. Those of you who want to go for R&D, those who want to go into drug development, drug delivery, so on and so forth, we need to find out how does this particular bacteria causes disease and how is it different from other bacteria, so we can come up with a mechanism to stop that happening. If the major mechanism is adhesion, we'll stop adhesion. If the major mechanism is invasion, we'll stop invasion. If the major mechanism is release of toxin, we'll come with antitoxin. If the major mechanism is for any other things that this bacteria do, we need to circumvent that. So that's a potential, a possible way for us to deal with this bacteria, right? So I would suggest to you that, especially for this chapter, bacterial pathogenesis, and also keep in mind for every system that you will do, viral pathogenesis, parasitic pathogenesis, there will be some similarities. And those similarities are coming from our immune response. But other than that, I just give you an example of reactivation. But that's reactivation latency is something that viruses do. But again, something can be common in bacterial for some specific nasty bacteria like Mycobacterium tuberculosis. And these are some important bacteria that you usually are tested for and asked for. Okay? Any questions?